Right. Good evening, everyone, and a very warm welcome to our Philips Cardiac Ultrasound Med Talk series. Um, Today is our first installment in a series of 5 Med Talks, and we have the pleasure of hosting Dr. Walter Serino from London, UK this evening. Due to the large number of participants, we will have everyone on mute throughout the presentation. I'm thrilled to have all of you here for this educational opportunity, gathered from across South Africa, Kenya, Egypt. We've got folks from Ghana and Nigeria and other parts of the world. I appreciate you making the time to join us this evening. My name is De Wet van der Westhuizen. I'm an advanced cardiac ultrasound application specialist for Philips in the Africa team. And it's really great seeing all of you tonight. Let me address a couple of matters before we begin the lecture. So throughout the lecture, should you have any questions, please type them in the Q&A section that you will find in your application, either at the top or at the bottom of your screen, depending on whether you are tuned in from your laptop, from your tablet, or from your smartphone. We will do our best to address all the questions at the Q&A session at the end of the talk. Saying that, we may not make it through all of your questions, but we will attempt to identify as many unique and relevant questions as possible, and we will try and answer at least the most frequently asked questions. Thanks for your understanding. As you are all aware, the World Health Organization has declared the coronavirus outbreak as a global health emergency. We realize that COVID-19 has disrupted our world in many ways. We also believe that learning and education should not stop even in these very uncertain times. And from the onset of the pandemic, we have been brainstorming ideas on how to improve continuous education. Investment in education and its ongoing development is an essential part of the Philips strategy to better serve customers and to improve quality. As a leading health technology company, Philips has a broad range of ultrasound products, such as for cardiac and lung imaging. Allow me to quickly highlight our premium cardiac platform and some of its applications. The EPIC CVX is the Philips premium ultrasound platform designed specifically for cardiology. It offers tailored applications for adult, pediatric, and interventional echocardiography with faster data processing, sharper images, robust quantification tools, and customizable tools. The revolutionary Insight imaging architecture provides images with exceptional frame rate, uniformity, and penetration. Now, usually 1 + 1 would equal 2, but in this case, with this very strong combination, 1 + 1 equals 3. As most of you will know, TomTech is now part of the Philips family. In the next slide, you will see how we have seamlessly integrated one of TomTech's most trusted applications with Philips technology to bring to our users fully automated and easy to use strain quantification tools. I want to highlight our comprehensive auto strain solution. The clinical benefits of strain echocardiography are very well established, and echo societies around the world are advocating its routine use. In the setting of cardio-oncology, the use of GLS is established, and it's been proven to be the most optimal parameter to detect subclinical left ventricular dysfunction. Philips has a comprehensive strain solution for the left ventricle, the right ventricle, and the left atrium that is in alignment with the EACVI and ASE Speckled Task Force recommendations. All these applications are fully automated and are available on the EPIC and Affinity platform. I now want to transition to the world of 3D and focus on left heart volumes. Dynamic heart model removes the complexity of 3D quantification. It's fully automated application that quantifies the left heart volumes and ejection fraction within seconds. Image acquisition is very easy. Analysis time is fast, and the results are robustly reproducible, allowing you to incorporate 3D into your routine clinical practice. We have brought major advancements in 3D echo rendering. And before I give over to Dr. Serino, I want to present TrueView, which is arguably one of the most exciting applications in 3D echo, well, at least for me. So TrueView is photorealistic rendering of the heart using a virtual movable light source. This has got multiple benefits. One of them is to aid communication between the imaging cardiologist and the cardiac surgeon. Other benefits are the signal to noise ratio is better compared to kind of traditional 3D rendering. And you also really get to understand the depth in the 3D data set. So this is available on our Epic and Affinity, on our Epic CVX platforms. It now gives me really great pleasure to introduce our speaker for this evening. Dr. Walter Serino is a consultant cardiologist that qualified in medicine and surgery at the prestigious Emperor Federico Hospital in Naples in Italy. Since coming to the UK in 1998, he worked at the Basildon Hospital in Essex, UK, and at its cardiothoracic center since its inception. Over the last 8 years, he has single-handedly developed the perioperative imaging service at Basildon Cardiothoracic Center. He's got a keen interest in cardiac imaging and in echocardiography, and he has over 40 papers published in peer-review articles. Dr. Serino is a member of the European Association of Cardiology, of the European Association of Cardiovascular Imaging. He's also a member of the American Society of Echocardiography and the British Society of Echocardiography. Dr. Serino, it is a real pleasure having you this evening. Many, many thanks for your time, and thanks for being part of this very first cardiac ultrasound MedTalk series for Africa. Without any further ado, I'm going to hand over to you. You can now start sharing your screen. Thanks very much, and over to you.
Right. Thank you very much, David, for your presentation. Is definitely not, it's a sort of exaggerated one, and I don't, I wouldn't have been so emphatic. What I'm seeing, however, now is that it doesn't seem that the screen is working. So I'll try to share it again, starting from the beginning here, and see what happens.
We can see your screen.
Yes, but it doesn't move. Let's see. Sorry, thank you very much for everyone for attending this meeting. And of course, the hour is a bit late and you've had a full day work, so I'll try to be as short as possible. To complete what the wet said, even if we cannot answer all your questions today, you keep sending it, because we'll try to send some answer by email if you have your contacts or other, digital ways. Right, we'll deal tonight with what is still a continuing, ongoing challenge for the cardiologists. It's the mitral valve regurgitation, its mechanism, its measurements, and its management. There are many pressing issues in management of for the mitral regurgitation, and these are, the educational program that the cardiologists followed, the capacity to appropriately refer this patient, the uncertainty about the capacity of the surgeon to deal with it. But what is interesting for us is the quality of the imaging. They is still extremely variable. Before we proceed, I will poll you for a question. I would like to know, really, I'm interested to know how many of you are actually attending. Are you actually cardiologists? How many are physicians and cardiologists? How many are cardiac technicians? And how many of you are cardiac nurses? The reply will come shortly on our screen. The reason why the mitral regurgitation is so complicated is that because the mitral valve is not a simple structure. It's made by an annulus, leaflet and scallops, cord and papillary muscles, and the complex of papillary muscles and annulus and makes what is called the left ventricular annular complex, which is a complex architecture, which has, however, the scope of ensuring the proper effective contraction of the heart. On top of these complications, the mitral valve is actually not flat. It doesn't like flat. It's a saddle shaped structure without the complexity of the problem. Right, the panelists can vote now on the question I asked you. In meantime, we'll carry on. The saddle shape is also compounded by the fact that this valve moves in many directions, not a single direction. It moves on a vertical axis. These are all 3D images reconstructed from, from the movement. You can see a vertical axis. The mitral will also move. The annulus will shorten and dilate depending on the cycle. In systole will shorten, in diastole will elongate. And finally, it will also move in the transcommissural axis. So as you can see, these add to the complication of the situation. The Carpentier original classification of the mitral regurgitation is now nearly 40 years old. Distinguished the mitral regurgitation mechanism in 3 types: type 1, 2, and 3, A and B. Depending, however, on the functionality and integrity of the leaflets. So type 1 has normal anatomy of the leaflets. Type 2 has increased motion of these leaflets. Type 3A is restricted motion both in systole and diastole. Type 3B is restricted leaflet, the motion only in systole. Having a second look at these things, we realize that the type 1 and type 3 are actually secondary or functional mitral regurgitation, because the leaflets are anatomically normal. What is not normal is either the dilatation of the annulus or the dysfunction of the ventricle. While type 2 and type 3A are, thinking of it, a primary form of mitral regurgitation, because the leaflet are primarily affected. The recent guidelines in 2014, in fact, established this difference, considering secondary functional and primary functional and primary organic regurgitation. The secondary is the case in which the ventricular disease or atrial disease creates valve consequences. This happens in coronary artery disease, cardiomyopathy, atrial arrhythmias. The primary or organic is the valve responsible. The ventricle suffer the consequences. You are very familiar, I suppose, with the rheumatic disease. It's a bit less common in our neck of the wood, of course. Carcinoid, degenerative disease, radiotherapy, endocarditis are the causes. The reason why the guidelines put secondary in the first place is that the secondary MR represents actually 90% of the cases. It's much more common than the primary MR. The 10% of MR is represented mostly, at least in our countries, by myxomatous degeneration. In other countries like Africa, for instance, the other causes like rheumatic disease must be a bit more common. Let's review the situation and some images. The primary or degenerative MR, or DMR, as we say, is a disease of the valve. We already said that. The valve makes the ventricle sick. If you see this image, you will all recognize this is a mitral valve stenosis, where the thickening and immobility of the posterior leaflet is obvious. The margin of the anterior leaflet is also retained and calcified. The body is still free, will not last very long. In our countries, the most common, as I said, is the fibromuscular deficiency, or FMD, which is the type 2 situation. It has a full range of severity, from the simple billowing, which is 1 or 2 millimeters above the mitral annulus, to the complete prolapse, which is more than 3 millimeters above the annulus, to the flail, where one scallop is usually inverted and looks into the left atrium with or without ruptured cords. The secondary MR, as we said, instead is a disease of the left ventricle or the left atrium, which makes the valve sick. You will see here normal leaflets, all in all, with a dilated left atrium or annulus anyway, which makes the coaptation here very limited. That's the annular dilatation. The perforation again sees normal anatomy of the leaflet, but with a rupture in the center. But the most common cause of functional mitral regurgitation or secondary mitral regurgitation is the type 3B, or the tethering or apical tethering of these leaflets, which are more or less normal, but they are retained in an abnormal way toward the ventricle. This happens most commonly in ischemic restriction or ischemic cardiomyopathy and dilated cardiomyopathy. This apical tethering is the landmark of the functional MR. There are actually not only the tethering, there's a number of forces here at work. One is the apical migration of the papillary muscle and the apical tethering, but the papillary muscle might exert a traction which is different from each papillary muscle. There might be bulging segments depending on the ischemic or affected by coronary disease segments. And as a result, there is decreased closing force. So this causes what is usually a central jet of MR. On top of it, of course, there is annular dilatation when the ventricle dilates. So the central MR is one of the usually defining things of the ischemic or functional mitral regurgitation. Like in these two views, in the tethering and the lack of coaptation is here, and the central jet is obvious here. However, because there are so many factors at work, it might well happen that they are not acting symmetrically. So if one side is, say, pulling the string a bit more than the other, you might have what we call an asymmetric tethering, which causes the anterior leaflet to slightly jump over the posterior in what is called pseudoprolapse. In this, and the jet will be, as a result, eccentric. This is obviously the case here, where you have the two leaflets moving normally. Their coaptation is not normal. There is obviously asymmetric tethering, and this results in an eccentric jet. There are a number of things we can easily look at when we dealing with the functional MR. This is a TOE image, but you can obtain roughly the same details from a transthoracic apical view. You can measure what we call the tenting or tethering, the height of the tethering, or tenting height. That has to be less than 11 millimeters. If it's 11 or more, then this is abnormal. You can see the coaptation zone here. It has to be more than 2 millimeters, otherwise there won't be coaptation. You can calculate the entire tenting area. There should be less than 3.4 square centimeter. And you can measure the angle between the two annuli, mitral and aortic, and the length of the anterior leaflet, which is useful for the surgeon for many things. However, the big ongoing challenge is the grading of MR. When is it that we can define mild, moderate, or severe? Let me take a quick break. If you want, you can drink from your glass. Right, okay, we have quite a number of cardiologists and physician cardiologists, and the majority of cardiac technicians with some cardiac nurses. Excellent, it's a very good mix.
Dr. Serino, sorry, it's just we've neglected to put cardiac anesthesiologist there.
Yes,
so
that's right.
Apologies, that's an oversight from my side, and we will fix it moving forward.
On my side, but I assume that they are in the physician category, meaning non-cardiologists originally. So if they want, they can include themselves in that category. The next poll is about which is the most common measure of mitral regurgitation severity you use in your reports. The Doppler envelope, the color flow jet area, the vena contracta, the PISA, or others. So you can vote, and we'll have the result in a little bit. Meantime, we just carry on with our discussion. In the grading of the MR, there have been devised a number of methods, qualitative methods, semi-quantitative ones, and quantitative ones. Let's examine them in detail, but shortly, not stay too long on each of them. As qualitative methods, the Doppler envelope is the one that first comes to mind. It's easy to obtain. It's useful to suggest, suggest if it's mild or severe MR, and it's useful to detect what is a non-fully systolic, non-holosystolic MR, like in hypertrophic cardiomyopathy and SAM. The drawback is that this is not specific at all. It's no good at all for the definition of moderate or moderate severe. You'll see here two examples. On the left is an envelope which is definitely complete, but its haze is not very dense. It suggests, again, suggests only mild MR. On the right side is a very dense but triangular shape of Doppler through the mitral, which suggests, again, an acute severe MR. And this is what I was mentioning earlier, the non-holosystolic MR. For instance, in this case of prolapse, the MR happens only at the end of the systole. The second method, everybody will know that, that's the color Doppler. Very easy to obtain, immediate to obtain, is a yes or no report. So it tells you, yes, there is or no, there isn't severe MR. And it's useful for leaflet pathology based on the jet of the direction, with direction of the jet, with the exception we mentioned earlier. It's definitely the most common and quickly and widely used. However, be very wary. The color flow is a mean pulsed wave velocity map. It's not a flow, it's a velocity map. It's affected by the settings of the machine with the phenomenon of dial leak, we'll mention it later. It's affected by hemodynamics, like the blood pressure, by the view in which you see it, and by the shape of the orifice. So many careful things. The way we are judging on the amount of MR based on the color flow, yes, that's we are. Color flow jet area, that's what we are talking about. Excellent, that's very interesting, this one. This is the way we normally use to say if the MR is severe or not, based on the size of the tomato. Have a look at the next slide, though. This is the representation of a flow of water from a hose. In the first instance, mind you, the flow on these two images is exactly the same. In this one, the velocity is lower, and the jet will be represented as small jet. In this one, the velocity will be higher, and this will be represented as a bigger jet. But the amount of flow is exactly the same. So that's you have to be very careful about. And you have to pay attention to a number of tips. You know, the color gains. If you increase or decrease the color gains, the amount of color flow map changes. From this point of view, you have to all align with one simple device of turning the gain up to the first noise that you can see. And when you get there, turn it down 2 clicks until the noise is gone. That is the most appropriate gain level. You have also to be careful that the Nyquist limit of the velocity on the scale is not too low, because that will transform it in a huge jet. And the recommended level of velocity on the scale of your machine is around 70 centimeter per second. Also, for those of you that use a lot of pediatric probes, the pediatric probe will make the jet thicker because of the transducer frequency, rather than a 3.5 megahertz normal adult probe. But all in all, this technique is very good for defining if the jet is functional, central, or rather eccentric and, you know, primary or organic. So this is good. And one more thing, you have to look at it in different views, because in this view, the jet is this big, but in the same patient, in the same sequence, in another view, the amount is completely different. So careful. So remember, for color Doppler, yes, use it, but remember, the large color doesn't mean a large flow. Use more than one view, check the color gain. Make sure there's only 2 clicks below the noise level. And above all, forget the good old eyeballing. Don't rely on that. Right, let's move to the semi-quantitative methods. There are 3 of them mainly: the mitral inflow, the pulmonary vein systolic flow, and the vena contracta. I mean, we all know these things. I'm only trying to tell you, yes, you can use it, but also how you have to be careful in using them. The inflow, the mitral valve will give you usually an E and A here. If you see an E wave that whose peak velocity is less than 1 meter per second, it's unlikely that there is a severe MR underneath. Conversely, if the peak velocity is more than 1.2, 1.5 meter per second, you have to suspect a severe degree of MR. Of course, this is affected by the mitral valve itself. In a degree of mitral stenosis, the generational sclerosis might affect that. So it's not entirely reliable, and again, doesn't distinguish between moderate or mild, moderate or severe. A second, bit more time-consuming method is the pulsed wave mitral aortic VTI ratio. You have to calculate the VTI of both the mitral valve and the aortic valve by measuring the annulus of the mitral valve, the annulus of the aortic valve, or better, the LVOT under the aorta, and then the transvalvular Doppler, creating what is called the VTI, or velocity time integral. The ratio of the mitral to the aorta is usually less than 1. So the aortic is more than the mitral. But if the mitral ratio to the aorta is more than 1.4, this suggests a severe MR. Quite a number of possible source of errors, like the measurement of the LVOT or the mitral annulus, and the exact alignment that you have to do to obtain a good Doppler. And again, doesn't distinguish between moderate and severe. This one is a bit more used, the pulse wave of the pulmonary vein flow. They always recommend to do it, and to do it at least in 2 pulmonary veins, not only 1. In normal cases, you have a flow that is represented by a systolic and a diastolic hump, and the reverse flow in the atrial systole. When the severe MR is present, the systolic peak is mostly damped, or even in severe cases inverted. But again, if you are in atrial fibrillation with high LA pressure for other reason, this can interfere with the systolic flow and the measurements. And finally, the vena contracta is probably the most known of the methods. I've seen that some of you like to use it, and I would agree that can be done, it should be done. It is the narrowest portion of a regurgitant jet stream, of course, and you have to optimize the image for high temporal resolution, angle, transducer to get the best image. When you measure this narrowest bit here, you can have a measure below 3 millimeter and in large cases above 7 millimeter. Below 3 millimeter is considered always a mild MR. 3.1 to 6.9 is a large range of moderate MR, and 7 millimeter or more is supposed to represent a severe mitral regurgitation. It's all very simple and it's all very quick to obtain. There are a few caveats, however. It's definitely not an accurate method when you have an elliptical slit-like orifice, which is the most common situation when you're secondary or functional MR. So you see, this is the rounded orifice. This is the elliptical one. So you have a completely different view of the vena cava, vena contracta in this case. The single frame might overestimate the MR if you take it during a late systolic prolapse, because you take it during only a part of the systole and therefore cannot represent the full MR. And multiple jets, like in this slide, well, you tell me where you want to measure, and I'll tell you that's probably not appropriate. So we are left with the quantitative methods. Now, these are a little bit of a trick, however. Let's examine the two main ones. You have favored the PISA method. We'll come back to it in a moment. There is another one which is called Doppler regurgitant volume. In itself is a decent measure. It's numerically pretty sound, but you have to calculate the systole and diastole of the left ventricle and do the difference to get the LVOT, to get the LV stroke volume. And you have to calculate the LVOT stroke volume. So when you do the LV stroke volume minus the stroke volume 64 minus the LVOT stroke volume, you obtain what is called the mitral regurgitant volume, which divided by the diastolic volume creates the, gives you the result as regurgitant fraction. Now, this is, you know, is easy to obtain. I mean, it requires a few calculations. And as I said, it's numerically sound. However, where is the catch here? It's operator dependent. Bear in mind that in the best laboratories, the interoperator variability when they measure the LV by Simpson biplane is 10% or even more. Today, the accreditation of a lab is also based on the fact that it's below this level. Also, the LVOT stroke volume is subject to square measure errors. You know, in the formula, is a 2 pi r square. Means every little millimeter of difference makes a big error. And it is also, the LVOT measurement is also flawed by the fact that we assume it's geometrically round, and in a 2D image, we have no idea in which position we are. Okay, so let's move to the PISA. PISA gives as a result what is called the effective orifice area, effective regurgitant orifice area. You know all this. I don't need to tell you. The only thing I want to make sure is that you understand that this is valid because assumes, or when it assumes that the orifice is a round orifice, and therefore that the assumption that the convergence area is a hemispheric one. With the calculation, the PISA, with radius, the alias velocity at the VT or the velocity, peak velocity, you can calculate both the regurgitant flow, the effective orifice area, and the regurgitant volume. This is definitely the most used measurement in the world currently. However, you need a few caveats, few tips actually. You need to obtain the best alignment with the color flow. You need to set the baseline shift to about 30 centimeters per second and decide, and that's a bit dodgy, where to calculate the PISA radius. If the PISA radius is already more than 1 centimeter, and you've done all the rest properly, you're already sure that the MR might be severe. And then you calculate the peak velocity here and the VTI of the transmitral regurgitant flow. This is a case of mild mitral regurgitation, a calculation of 20.2 square centimeter and 27 millimeter of volume. And this is an example instead of severe MR with a resultant PISA radius of 1.21 and a regurgitant volume of 77, effective orifice area of 61. So the resultant HEROA or effective orifice area is a sound measurement. It's the most used quantitative MR measurement and is fully validated data. And its correlation with clinical outcome very well recognized. The drawbacks, however, are the effective orifice area again is underestimated with the function mitral regurgitation occurs because the orifice is slit-like and in case of multiple jets. And it's also very operator dependent because it's subjective to the choice of the right frame used to measure. For instance, that's the same patient. The operator 1 chose this frame and he calculated an RO of 0.2 and RV of 43 milliliters. But the same patient with a frame chosen by a different operator gives a very different result, 0.1 square centimeter, 32 milliliter volume. So you see, it gives you a completely different result. I would like to ask you if you are still with me. But anyway, I assume that after this quick discussion, you understand that there are usefulness, but also limits in the basic techniques that we use to grade the mitral regurgitation severity. And what actually is the severe MR? Well, it's no good. Thank you very much. We all knew that from the beginning. The thing is, we don't know exactly what we call severe mitral regurgitation. I'll tell you why. Because in the listing from every recent guidelines until 2014, there is a number of numbers. We all know that. They're all listed in all the articles that are available. And they're mostly consistent for primary or secondary MR, with one huge exception. Exactly the PISA and the regurgitant volume, which we say that the most used measurements, are different or were different between primary and secondary MR, where the secondary MR had a lower threshold to consider severe compared to the primary. Now, this has gone on until a couple of years ago, 3 years ago actually, when a review of the entire methodology brought to a surprising conclusion. The recommendation, this is agreed, AHA, HCC, and recently also the European Society. The recommended definition of severe secondary MR has to be the same for primary and secondary MR, and has to be set in 0.2 square centimeter for the effective orifice area and 60 milliliter for the regurgitant volume. However, there is an understanding that the effective regurgitant orifice cutoff of 0.2 is certainly more sensitive, but the 0.4 square centimeter is more specific for severe MR. Therefore, they suggest to adopt a single measurement. This is the same list that comes in the same publication. It's Zogby in the Journal of American Society of Echo in 2017, which beside introduce also the measures approved for evaluation of intermediate or moderate mitral regurgitation. We'll come to the moderate MR toward the end of this discussion. And this is, of course, the summary of the guidelines. I would like to, draw your attention to the red circle here. They always recommend to perform quantitative methods whenever possible. So, no good old eyeball. Color flow is fine, but only if put in context with all the other measurements. In summary, the Carpentier classification helps in defining the mechanism and the leaflet dysfunction in a direct repair and intervention. The revised guidelines now put primary and secondary MR on the same level, but gives you stage of disease and indication for intervention, as I will see later. However, the sad conclusion is there is no single reliable measurement of severity available. So the guidelines recommend to use of quantitative methods and to include as many criteria as possible. You have no fear. We have novel technique coming to help you. Right, last question for everyone before I go on. How many of you currently have possibility of a use of an echo which is 3D capable and with an analysis workstation like GE EchoPark, Philips QLab, Siemens EC, or Camtech or others? Just say yes or no. Meantime, we'll go on. So the third bit of the quantitative methods are the novel techniques. There are non-echo and echo techniques. I mean, we can't forget completely the non-echo techniques because CT and CMR are today really doing giant steps of quality. They allow really to get an unimaginable clear view of the effective orifice area, shape and size. And they are unaffected by bone and lungs. You can calculate ventricular performance without any interference, without geometric assumption, with excellent contrast. And the recent CMR techniques allow you to distinguish between primary and secondary MR. However, don't forget that echo is your friend. And there is a fundamental reason, a fundamental difference between CT, MRI, and echo. This is a portable MRI or CT. This is a portable echo. So you'll see the difference here. Right, there are numberless papers talking of the new breakthrough in measurement of the MR but on many other things, which is the 3D echo. Great. Quite a good percentage still has available these machines. 63% they don't have. I hope that at the end of this discussion, you'll understand why you should turn the tide and try to fight the battle to get a 3D echo machine. I mean, my first 3D echo was in 2002, I think 2003, but there's been huge progress since. 3D echo, especially the transesophageal echo, does allow accurate visualization of structures in their spatial position. That's the difference. And structure and flow in areas that are not otherwise accessible by 2D echo. The 3D echo will also allow automatic operator independent measurements. We'll see why this is important, because it reduces errors and variations. And is a true revolution in imaging, as DeWitt hinted earlier, because makes the surgeon and the cardiologist able to share a common language, finally, after decades of talking in right, left, upper, lower, and things like that. Right. This is an echo that shows, structures in their spatial position and striking details. This is a sort of what DeWitt mentioned as transillumination. There are other machines also available, similar sort of performance in the end. You can see a prolapse of the posterior leaflet, P2, with 3 at least ruptured cords. This is important because it defines which is which, where is what. The reference point are known, and we'll see why it's also so important. Apologies for the quality of this picture. Is taken from a screen. In this case, we detected with a 3D echo an accessory scallop, which would not have been clearly identified or classified as such in a 2D study. And why is that important? Because the possibility of repair and mitral regurgitation due to P2 is very, very good, nearly 100%. But when anterior scallops or posterior non-P2 scallops, that is much less uncertain, the result. Also, with 3D, you can eliminate all the uncertainty about calculation, for instance, of the left ventricle volume and function, because these techniques are now operator independent and robustly reproducible and take very short time. And also in a 3D, you can finally have the image of a slit-like orifice and measure it. And so you're out of any doubt when it comes to this occurrence. The important thing, at least from my point of view, is that the 3D allows surgeons and cardiologists to talk exactly the same language. If you see here on the left is what the surgeon sees when he opens the left atrium. On the right side is what we see on transesophageal EOE. But we have an advantage. We are seeing the thing in motion. The surgeon sees only when it's dead and there on the theater and on the operatory room, and the heart doesn't move. So we have a big advantage. But we speak at this point the same language. The 3D has got other issues, other advantages, which will all factor in when you need to do calculations to calculate the MR severity as well. In fact, you'll be assisted in overcoming the errors caused by geometric assumption, we say then. And you can be able to calculate multiple parameters in an operator-independent way and in much shorter time. This shows why we are having a 3D discussion, because normally we assume that the PISA, for instance, just to go back to the PISA, is an hemispheric area. Well, at most, with some formula, we can transform it in an elongate ellipsoid, but that's all the thing that we can do. If we measure this MR based on vena contracta, we have a kind of result 0.6, which suggests that MR is severe. We use a PISA, and in the transthoracic echo, we can barely get a 0.2, 0.15 square centimeter. 3D PISA gets rid of all the uncertainties because it calculates when will be available on all machines. We'll be able to calculate the entire bubble here, and therefore its calculation of 0.53 will be most accurate. And the surgeon will be much more happy to consider a certain consistent response rather than an equivocal one when he is to agree with us on a surgical intervention. The TOE, well, the 3D will also apply its capacity to a number of calculations, produce a number of calculations starting for only few, you know, landmark point here. And the product will be instantly there. And will also produce calculations which are useful for the surgeon, which will never be able to produce from 2D images, like leaflet area, annulus area, tenting height, tenting volume. I must say this image was from a journal of anesthetics, so I pay respect to our colleagues anesthetists in the audience. You'll also be able to build and construct the annular geometry, the interannular angle, which are all things which are extremely useful in the decision making. And finally, we'll also create a dynamic model of the mitral valve annulus and leaflets, which will potentially enable us to plan better repair and design and produce better annular rings. So we are aware now of the challenge of establishing the MR severity. How do we manage? Unfortunately, I got only a few minutes to do that. We need to know all the causes of the MR, primary, secondary, and mechanism, and the reliable assessment of severity. And we have to have decision making to decide if the MR needs to be operated or not. There is no doubt that the MR is bad from every point of view. Whichever point of measure you take, the outcome is worse, both in primary and secondary circumstances. However, when we go to the guidelines, the primary MR enjoys really a huge number of surgical indication, while the secondary MR is only a poor, only isolated 2B indication. Things are changing. But the reason for this difference is that while all publications say that MR does better with surgery rather than treated without surgery, in the secondary MR, this doesn't seem to make a big difference, except that things are changing. This is the latest guideline where there is an addition here, which says guideline directed medical therapy. So you have to make sure in secondary MR, you do everything according to the guidelines until you cannot do anything anymore. If despite that the symptoms are still there, the MR is still severe, you have to ask you if you have an end-stage heart failure, in which case there is no procedure indicated. But if it's not an end-stage heart failure, there are surgical or most likely interventional procedure to repair this mitral regurgitation. This leaves, however, one last point, which is the moderate MR, what we do there. And I would to introduce here the fact that in this case, you need to have further tools in your armory. You have to be able to do a stress echo and a strain, of which we'll talk at the next meeting. And if this demonstrates the situation is stable, then you can wait. But if demonstrates the situation is deteriorating, you should really take an interventional approach. Now, I understand that all this has been difficult to digest, so many things. And I understand if you're still in doubt, in which case I suggest that you ask the experts. I would stop here and ask you to go to the question, ask the wet if he has any question we can answer, or we can answer later on. Thank you very much, everyone.
Thanks, Dr. Serino. Thank you very much. That was extremely insightful. And thanks very much. So we have 5 questions that came in. Okay, so we've still got a few minutes left. So let's quickly run through them. So the first question is, if there is a flail leaflet, can we assume the MR is always severe? Can you perhaps comment on that?
Yes, that's a good point. The flail leaflet gives always an eccentric jet. And often this eccentric jet is misleading because it might look a very thin one, and because it goes and hugs the wall of the left atrium, creating what's called the Coanda effect. by definition, when there is a flail leaflet, we have to assume that it's severe MR. Even if we don't see it, if we cannot ascertain properly, even if we don't have a 3D to see the width of the jet, we have to assume it's severe. Not only that, but the flail is eminently correctable. So no reason not to do something.
Okay, thank you very much. I think that's clear. Going to move to the next question. I think you've briefly mentioned this already, but from a cardiac surgeon's perspective, how much value does 3D echo add in planning of a mitral valve repair?
Now you touch a point which I only skipped on, obviously, because of the time available. But this is a huge difference. I've been working with the surgeon, as you said, for 8 years, more than that, in many different settings, including in Ethiopia and in Pakistan. And the surgeon made this notice. They say that if they see what they are doing, what we are dealing with, when it's in motion, they can plan a completely different, they make a completely different plan. The fact is that while we were in Ethiopia or Pakistan, we didn't have a 3D. And in a couple of times, we would have really made a different choice at that point. But also, we ran a study in which we run, the number of patients operated for repair of the mitral valve, with or without a 3D image. And we realized the 3D image and the perioperative imaging reclassified about a third of these patients toward a different plan. So it is a breakthrough and is massively important. Nowadays, repair of the mitral valve is not considered feasible without a 3D TOE on the table.
Okay. Wow. Okay. Thanks. So there's quite a strong motivation for using 3D TE in the mitral valve arena. Thanks for that. Next question is, please can you share tips on how to best get the pulmonary vein flow as a marker, of MR severity? Is there any top tips for us, Dr. Serino?
Right. The tips are, you normally do this in the apical views if you are doing transthoracic, of course. We assume transthoracic here. Well, the problem of this is that you don't often have a good enough image to identify at least 2 pulmonary veins. But if you work a lot, if you have the patient lying on the left side, if you take any possible measures to guarantee, for instance, a brief breath hold, suspending the breathing for a few seconds, you can get images good enough to obtain the image, the flow in the pulmonary vein. The thing is also true that in many patients, which are large patients, this becomes a very far, object. It's in a very far field, and the pulsed wave is very good in the midfield. It becomes a little bit more dodgy in the far fields, especially if it's more than 20 centimeters. But I've seen technicians with, obtain the results in 90% of the cases with a bit of care and a bit of, time spent on positioning the patient.
Okay, thanks for that. I think that answers the question very, very clearly. Now, the next 2 questions has to deal, by the looks of it, with multi-valve pathology. So, and I know this is quite a complex, clinical scenario. So, if you don't want to dive into too much detail, it's fine. Let me just quickly read the question. So basically, it's saying, can you please tell us how to grade mitral valve regurgitation in the setting of severe AS? And the next question is also the effects of MR assessment in mixed mitral valve plus aortic lesion. Your comments, please.
Right, that's a comment that will require a full discussion, of course, again, from the start. The only thing I would say is that we still don't know, okay? So we don't know what to do about multivalves. Yes, we measure the MR in the possible way, but as I said as I showed in the presentation, many of the measures are actually affected by the balance of flows and pressures. And therefore, an aortic stenosis will inevitably increase the amount of mitral regurgitation just because of the enhancement of the pressure difference between ventricle and left atrium, not because the MR is actually necessarily that severe. So there's been a number of papers on the matter, and they have come with a very nice conclusion. They have to say, oh, you know, because it's so complicated, it's better if it's a decision taken by the heart team. Which means that when you talk of complex valve, actually, when you talk of valve and surgery, or when you talk of surgery in general, you have to have a heart team on your back with the anesthetist, the imaging cardiologist, the radiologist, and the surgeon. And they have to balance a number of issues, like, for instance, you know, the symptoms, the severity, at least for what you've been able to measure of each of the valve involved, the additional you know, surgical risk that a different surgical plan entails, and also depending on the locality where you are, the possibility of proceeding in stages with use of, for instance, interventional procedures rather than surgical one, because you can today fix, say, for instance, a mitral regurgitation in an 85-year-old patient with multimorbidities in the conviction that tomorrow, if it's necessary, you can really do a TAVI for the aortic valve and sort the problem with a staged approach. So, you know, it's a very complicated situation. And I think that what we do, we go anyway with what is the main valve, the most severe of the valves, and judge the second valve feasibility based on that one, and with the help of advice from the surgeon, anesthetist, and so forth.
Okay.
But it's not an easy, an easy question. It's not an easy answer at all.
Yeah. Okay. I see. Thanks, Dr. Srino. It has gone 8 o'clock, but I think this is such a stimulating conversation. I think we can press on for 5 more minutes. If anybody does need to leave, please do. I think if we can tackle maybe 2 more questions. Right. Next one. If we see multiple small MR jets, how do we quantify the severity in your practice?
Right. Well, that's a good question, because after all, what I said is that you cannot easily measure multiple jets. The ideal report is, or answer is, if you have a 3D TOE and you can obtain a decent image of the jets, because you will see the jets in short axis as single orifice, you can sum up the single orifice to obtain a global orifice. Okay, you cannot do that with vena contracta, because the vena contracta measured on 5 jets or even 3 jets will create only confusion. Although in that case, when you have the vena contracta, arguably you can judge on the worst of the jets, but this will leave still outside the other 2 or 3 minor jets, which might contribute to the severity. But the ideal one is, and this is what we have done over the last few years in theater, is measure the effective orifice area, not with PISA, with anatomy, so a color anatomy, so we can measure the single area of single jet and sum them up.
I see.
All in all, that if it's not possible, the only other option is looking at the major jet, assess it, and also judge on the indirect signs like dilated left atrium, symptoms, and other situations. But for instance, the multiple jets is typical of the Barlow valve, of the prolapse of both leaflet, large prolapse of both leaflet. It's very unlikely that is mild. It's likely to be more than mild generally, but it's also true that the Barlow valve is not easily repaired surgically, so it would entail replacement in many cases, and this will drive the surgeon to think twice before operating, especially if this is an isolated lesion.
I see. Okay, I trust that answers that question. We've got a comment here, I believe from one of our anesthesiologists, saying 3D echo revolutionized mitral valve repair, and I think we can agree with that. Maybe if we can do perhaps two more. So next one is after CABG surgery. Immediately after surgery, if the MR goes from mild to severe, what shall we do? What shall we advise to the surgeon? So immediately post CABG, the mild MR is now severe. What do we what do we tell the surgeon?
Good point. It happens
Yeah.
sometimes. Now, in these cases, what you have to do is first make sure that there is no segmental wall motion abnormality which wasn't present before the operation or the start. Which will, if there isn't, this rules out a technical problem with bypasses, of course, and leaves you with a need to improve as much as possible your medical therapy and support, and see if this MR tends to decrease. If it decreases in a reasonable time, and usually it happens, I mean, the vast majority of patients who shows increased MR immediately after bypass improve with the appropriate therapy. You know, nowadays, one of the therapy that is used most in these cases, and which wasn't available a few years ago, is the ionodilators medications like the one that the anesthetists know very well, and I know it as well. You know, anyway, one of these medications which improve the contractility and decrease the resistance. Milrinone, sorry.
Yeah.
Okay. The milrinone and diuretics will help very much. It's the same criteria that used when they say use every guideline medication before deciding that secondary MR is severe. Because in many cases, when you improve and optimize the treatment, the MR decreases. And this has been seen so many times. So the first attempt is, well, rule out the technical question. And the second one is increase the medication, including milrinone, diuretic and things, and see if the MR decreases.
Okay, brilliant. Thanks, Dr. Serino. So, look, it's gone 5 minutes past the hour. We've got 2 more questions. One is quite complex about TAVI. I think I know asked the question, and perhaps I'll email this question to you, Walter, if you don't mind, and we can get it answered. But I think in the interest of time, this concludes our very first cardiac med talk. I want to thank all the delegates for your participation and your engagement. And again, Dr. Serino, many thanks for this very insightful talk. We really appreciate it. I want to just remind.
It's been my pleasure.
Thanks,
really.
Thanks so much.
Thank you.
I want to remind all delegates that we have Dr. Wei Lee from the Royal Brompton in London next week, talking about right ventricular assessment from basic to advanced imaging. The week after that, we've got Professor Roxy Senior, who's going to speak on discordant aortic valve stenosis, which is a fascinating topic, also from the Brompton. And then Dr. Serino will finish off with 2 more sessions.
I want just to say, please don't miss these 2 other colleagues. They are the top in their game, and it's really worth listening to them, because you won't probably get, easily a best presentation from them.
I agree.
Thank you very much to everyone.
Thank you. So not to be missed. Okay, well that's all from our side. Many thanks for tuning in. Stay safe. Have a good evening. Good night.
Good night.